Hi, I'm Cherise. I'm the coordinator and midwife for the Women's Individual Needs Clinic at the Women's Hospital, which is a maternity care for women with disabilities or conditions that impact their activities of daily living. You and I, Abby, met after presenting at a conference, and we started discussing about autistic women and maternity care and just some of the issues that we found that had arisen in regards to autistic women, and that the current system wasn't really meeting the needs of autistic women, that there was a lack of general knowledge and awareness from clinicians in regards to autism. And I don't think it's that people don't care. I just think it is purely lack of awareness. And I think clinicians are seeking or wanting to seek knowledge. So this is how this became about, that it would be good to build some, modules that were able to be educational for clinicians to improve their knowledge.
So what do you feel like are some of the top strategies that are working for your clinicians right now and for you when you work with clients that come through WIN and identify as autistic or neurodivergent?
I think it's really a neuro-affirming care in a sense that you have the right language, terminology, that you are, presenting as an ally, and that you understand their difference, and not approaching it in any judgmental way at all. Like when I see the women, I will generally say you've been referred because of you're autistic or you're ADHD or you're neurodivergent. And we sit and just have a general conversation, and I'll ask them about their sensitivities, their sensory sensitivities, and I'll sit down and we'll go through the list of, do you have any auditory? Do you have any tactile? Do you have any, that sort of thing? Go through and allow the women to describe in their own words what their sensitivities are. So I find it's really helpful to put like the heading of like tactile, and then them describe, do they, they might like soft fabrics or, whatever. We had one woman who found it hard for the warm water in the shower to touch her skin, and it would take 10 minutes to get under the shower. So I think it's really good to tease out that individual person's sense, because you're trying to develop a plan so that when they come into the hospital, they're admitted into the hospital, we've got all that noted down. So and in an individual sense, not just cookie cutter. Someone's neurodivergent, so they're going to have sensitivities. It's like what is that person's individual, and I think that's really helpful for the midwives or the clinicians at any touch point to have that knowledge in advance. Like when I do the childbirth information sessions, I will say to them the time that and I ask them about overwhelm. What does overwhelm look like for them? Do they stim? Do they use fidget toys? And I think just when you're asking those questions, they automatically, I feel you automatically get a sense of, oh, you are an ally, you understand it, because you're using the terminology, you're asking about them and their individual need. And that's why we called it the Individual Needs Clinic. So when I do the preparation for birthing, I'll say the time that you're probably going to become overwhelmed is when you're in the birth centre and you're having a baby. So I say to them to do a birth plan, and quite often I will also ask if there's a partner. Is your partner neurodivergent as well? Because it's not uncommon for pregnant women to have also a neurodivergent partner. I'll ask them, is there whether they've had a diagnosis, because as we know with social media, there's a lot of people that feel that they might be neurodivergent but not have had a formal diagnosis. So I do think it is helpful to know if there's a formal diagnosis. And, you might have I have a lot of people that might say, I was diagnosed with autism, blah, blah, this time. And I've been sent to see a psychologist, or they might have been all diagnosed with ADHD and since seen a psychologist who says, oh, you meet the criteria for autism, or you meet the criteria for, but it's still that's still not a diagnosis either. So I think it's important to tease out who has actually got a formal diagnosis and who has met the criteria and who hasn't even seen a psychologist at all, just to give me a little bit more understanding as to, the likelihood that this is being addressed out in the community by other services, and then who's involved, like who is your psychologist, are you still engaging with them, what sort of support have you got out in the community, so can lead to that when you know that there's been a diagnosis. And then if there's no diagnosis and they say, oh, I just feel like I feel like I've watched things and I think that's what I've got, you can then, that sort of segues to, well, why do you think that? And sometimes it's not even, because some people can't afford to get a diagnosis. Like something that I found, and you could maybe enlighten me even on this, is that as far as I'm still aware, it's not possible for an adult to get an autism diagnosis through the public system. They still need to pay. Because as we know, with females, for many years, it was on how males presented, and we know now that females are presenting differently. And so I think a lot of the women of childbearing age have not had the opportunity to have diagnosis as a young child. So therefore, I feel that they're really disadvantaged, because without a formal diagnosis as well, you can't apply for NDIS. So they're actually very much disadvantaged in the community, because they may have gone through their whole life up to this young adult age and never had any support whatsoever. And we know that the earlier support starts, the more likely they are to benefit from that in their everyday life. So you might have a woman present to you in the clinic that has never ever had any support in the community. He feels that they meet the criteria themselves of neurodiversity. They may have had a child that's been diagnosed and going, oh, hang on, I think that's me. But they can't get a diagnosis anywhere. So you've got a woman that may have, maybe potentially level 2 autism, having a child, and who can't get a diagnosis, to then be able to get appropriate support through NDIS, which I find for that cohort of women that I'm caring for quite problematic, because it's really unfair. Because they may not have a few $100s or a couple $1,000s to get the diagnosis. So I guess, talking about all that's really important. And then if they do have a formal diagnosis, do they have NDIS support? And then I guess looking at what that NDIS support is like, because when you're having a child, what you may have needed as potentially a young single person might now be different as you as a mother. And so do you need to be looking at change of circumstance for your NDIS? And getting that support to help get that change of circumstance, a referral to an occupational therapist who can do an assessment and write a report for change of circumstance as well, as to what some of the supports you may need when you're becoming a mother. So all that conversation is really important, and it makes a big difference to basically preparing for discharge from hospital and linkages into the community with the right supports to help. Because also autistic, women quite often like a lot of routine, and the time that routine is going to be thrown out is when you have a baby that's waking and crying and needing to be fed. Also the crying baby needing a lot of, holding, so there could be tactile, overwhelm sort of thing that the mother, or sound. So, we talk to them about, the ear, wearing ear muffs, all that type of thing. So I think it's like giving the person's information so that they've got strategies for when they've had the baby to maybe be dealing with and being prepared for some of the challenges that may happen. So I think, and as I say, I like them to do if they are happy to do so, a birth plan where they will put down, there's usually in some templates like a bio where you can put down, about yourself. And I say, and if your partner's happy, to also put down about your partner, and especially in regards to overwhelm and how do you reground yourself, so that if the partner starts pacing, they're not going to call security and think, oh my God, what's happening here? They might look, it's all here in front of us. We know when he's feeling a little bit stressed or he's getting, overwhelmed, he'll start pacing. This is he likes to just be left alone and he'll be fine. So I think that all that coming into hospital for admission, all that information gathering is so important, so that each touch point that person goes to in the hospital, there is a written, I guess, information on what this person's individual situation looks like. Yeah, I think when someone's coming into an antenatal appointment, it's a 10 or 15-minute appointment. And, it's not, we know that women can mask better than men often do. So when they come in, they can present, as clinicians often like to say, high functioning, but I don't think that terminology is right in this sense, because, we've had scientists and people like that, in having antenatal care, but it may not, yes, they're holding down, jobs and they're, living in the world and quite independent, but their lives are difficult. Their everyday challenges in their lives are difficult. And so there can be situations where they are also more likely potentially to be taken advantage of by men, because they, I've had women who are in situations where she's needed to be in hospital. It's starting to unravel because she's not able to mask for 3 days. And the partner may be neurotypical and he's presenting quite well, and they'll go, people, midwives or clinicians will take the attitude, oh, they'll be right, she's got her partner, she seems fine, she's, a scientist or she's whatever, they'll be fine. And, really not understanding that that's a really dysfunctional relationship that she's in, that he quite often can maybe, at that time was using her neuro diversity against her and saying, child protection, I could contact child protection, they wouldn't let you have your baby. And so there's always that fear of the authorities being called, and quite, can be quite abusive type relationships. And so I think it's looking at the woman and listening to her, not necessarily, just looking at this picture and thinking it'll be okay to discharge that person. I think we see women with, if women that have maybe had a late diagnosis or even have been diagnosed as a child but not had families that have been supportive in that diagnosis, have engaged in therapy, have been, caring and kind and loving and understanding of that autistic person, a lot of trauma comes with all that. And by the time they're reaching their childbearing age, they may have come, sometimes from quite dysfunctional families, and they've not only had to navigate that, but navigate that being neurodivergent as well in a neurotypical world. And that just can bring a lot of anxiety, a lot of depression, a lot of other mental health conditions, and the two mesh together can sometimes be hard to ascertain for clinicians. What is the neurodiversity? What is the mental health? And it's coming from yes, a trauma-informed care basis, but also neuro-affirming. So you can't, as we've discussed, you can't just be, trauma-informed. You also have to be neuro-affirming. And it's so multi-layered, and I think it's hard for people to get their head around it, and they just come across as the difficult patient, and they could come across as the rude patient, as the patient that's not making eye contact, and they may not be making eye contact because of their autism, not because they're being rude. So you really need that person that's there to advocate for them. And I guess that's what I try to do. Like, if I feel that there's some misunderstanding of how the patient's presenting, I'll advocate on their behalf. We are finding that that there's many autistic women at the moment that we're getting have got really significant mental health issues. And I think a lot of it's to do with the lack of resources that they've got in the community, and lack of resources for a long period of time. So even if they're coming in as a pregnant woman and then you're trying to link them into those services, you can't, it takes a long time to sort of, and a lot of understanding to work, I think, sometimes with women. We get so many women of like such a broad spectrum, like we get, like, that's the whole thing with neurodiversity. It's such a broad spectrum. Because you get people that may have some cognitive impairments, you get people that are high functioning in high, like, there you go, that word, high functioning. You get people that have good health literacy, people that have good formal supports, good informal supports, and then you get people that very little. So, yeah.
From your own practice and work at Wing Clinic, what have you found, and what kind of reassurance can you give professionals that there is kind of a go-to set of strategies that you give to someone who says self-identifies or has a professional diagnosis?
I think it's really important to understand those things that we discussed earlier. Even if you don't know that person's individual differences, I think that you understand, one, that there's different levels of autism. For us in the maternity space, most levels, we get most level 1, level 2. Because some people don't even realise, clinicians don't even realise there's different levels of autism. And that you just basically, if you just have an awareness that there are different sensitivities, and if you're not sure, ask them. Like, sometimes when someone walks into the consulting room, you can just say, I can turn the lights down if you would prefer me to. Or, that's just showing that you're being thoughtful. If that you're open to them, allowing them to be themselves. Is it asking them, like, we had a woman that wanted to go and speak to anaesthetist about her epidural and felt very dismissed because she did present quite well and she was probably masking at the time, and more or less got told, we do thousands of these a year and you'll be fine, and I don't know what you're worried about, basically, type of thing. I found like a lot of neurodiverse people, like neurodivergent people, they like a lot of information, like they want to know a lot about, like, and I think sometimes clinicians can sometimes almost think, oh, I don't want to give them too much information because it might make them worry more. But it actually has the opposite effect. It actually is more giving them more reassurance. So if anything, give them more information, let them ask, like really allow time for them to ask their questions. But then I find they don't want too much information on the negative things. Like, they want to know what the negative things are, but they don't want to know too much, because that can, for anybody, can be a little bit overwhelming and a bit scary. But generally, if someone's coming in and they're going to have an induction of labour, for example, step by step, what does that look like? And I think the more information you give, you'll know you're going to come into the hospital, you're going to go to this area, then someone's going to walk you up here. That type of information I find is very reassuring. So if anything, know the basic, about autism, about the levels of autism, and that determines sometimes how much support someone may need. Understand that someone can be masking and can be looking very cool, calm and collected on the outside, but inside their life may be behind the scenes quite chaotic. Just to get to that appointment may have been so stressful that by the time they've got to that appointment, they've forgotten what they were there and what they wanted to ask, why they were there. And yet they've come across really well in the appointment, and just understanding that, just allowing that time for them to ask, and don't dismiss. If they're asking a question, take it seriously. And that's for anybody. If they're asking a question, take it seriously. And that there are resources, and there's going to be this resource out there for clinicians. And yeah, I just think it's just treating people with just kindness. Like, a lot of it's just kindness, and friendliness. Like, just being kind and friendly is relaxing to people. If you go off, because as I said, they may have just to get to that appointment, they've had to organise to get themselves there. They've had to potentially struggle to get a car park. They're running late for their appointment. They finally get to their appointment. They're in a waiting room with fluorescent lights and lots of people. And so by the time they actually get in to see you, they can be so like stressed, and you just greeting them in a friendly, relaxed manner does 1,000 things to relax someone, I think, and as I said, being able to use the right terminology. If someone, like, I'll ask people, do they use fidget toys? And if they say, yeah, I do, I'll say, well, feel free to get them out. Like, if you want to get your fidget toys out, I'm fine with that, Or if I'll say to them, like, do you stim? And they'll be like fiddling with their rings, and they'll be like, yeah, this is me stimming, sort of thing. And it'll just be you understanding it's just building that. I think that whole sort of type of conversation just helps build that rapport and relax them, and that allows them to be more themselves. Someone looking at their phone might be their way of stimming, and it's not that they're being rude. And if you understand that I just scroll through my phone, that's how I cope with a stressful situation, then if the person's sitting there scrolling through their phone, you're like, oh, I know they're not being rude. And I think sometimes it's about letting down your own, because we like to be liked as well. And quite often it's reciprocal, isn't it? Like, that communication, as much as, like, as the clinician, you're wanting to think that the person's engaging well with you and is going to walk out the room thinking, oh, she was nice, or whatever as well. And that's just human nature, that we want that. So we're also looking for, I think as clinicians, you're also looking for that reciprocity, like that, that, and like, they don't always give you that. And so I think sometimes it's about forgetting about your own need to feel like you're being accepted by the patient. And it's not that they're trying to make you feel uncomfortable. It's just that they're not aware that they are even doing that. And yeah, I just think there is something about clinicians that we feel like we want to be feeling like we're being liked. Like, we don't want the patients to not like us either. And sometimes I think we're looking for that sort of connection back, and we're not getting it. And so, yeah, it makes us feel more awkward because we're not getting it, sort of thing. Whereas if you, right from the very word, like, have made them feel relaxed, that you understand neurodiversity, then I think they relax with you as well. Yeah.
So, like, I know you've talked to me before about, like, the simple accommodation of getting the anesthesis, I can never say that word, in to speak with the person beforehand and walk them through what that process is going to be like. Any situations like that have been really helpful for you or for the clients?
Well, we do a one-on-one childbirth information session because, it's better. Group sessions can sometimes not be as helpful as as they would like them to be. So having that capacity to have one-on-one childbirth information session, where I do one on birthing, one on feeding the baby, one on settling the baby, that is tailored to their individual situation. And so in that birthing one, we do talk about their sensitivities, what they may, like one person even wanted to bring in her own sheets because she liked the feel of her own sheets. And it's not saying, no, you can't bring them in. Like it wasn't like a no, you can't bring them in. But I did sort of say, well, you know, it's going to be hard to launder them and I would hate for them to go missing. But, you know, people can bring in their own pillows and they can bring in, like, if they, you know, other things that they want to bring, their, you know, their fidget toys. If they particularly want to, I've had people want to bring in their own towels and things like that. And like, really, that's not affecting us at all. If they're happy to bring in some of their own things, a weighted blanket, if they want to bring in some of their own things, that is fine. I think it's like that woman who the feel of the warm water touching her skin initially and taking 10 minutes until she felt she was comfortable to get under the shower. I think information like that's really important so that you can pass it on to other staff members, so that if someone's in labour and they're not going to say, hey, do you want to just go and get under and sit under the water, sort of thing, you know, just forewarning other, you know, clinicians of what may or may not work for that person is really important in making them feel like comfortable. And as I said, even understanding, you know, what their sort of sensitivities are. And I know the birth suite midwives really appreciate it, because that's the time when people are most like, and I often talk about the partner, and I say when you get overwhelmed, because a lot of people, when they get overwhelmed, they find it hard to talk, they shut down. So I say to them before the birthing process, if you're in that situation, are you happy for your partner to be communicating in the way that you know that you two communicate together, and to speak on your behalf? And I, you know, make a note of that they are happy, because, you know, sometimes we can get a bit antsy about like, oh, the partner's speaking for her and we want to hear from her and stuff like that. So I think that's important to establish if they're okay under that circumstance, and how do they normally communicate with each other under that circumstance, because that's where the partner or the significant person to them can be really important to have on board as well. Because they can actually help you with providing care. And so with us as well, we allow for the partner to stay on the postnatal ward with them, or the person that if they choose to have a person stay with them, just to make them feel more supported and help in that sort of recovery phase from having a baby. And we offer an extended stay. It's not you have to do anything. It's all like offering an extended stay to have the partner stay with them on the postnatal ward. It's all just reasonable adjustment, comes under that consideration of a reasonable adjustment. And I don't think a lot of hospitals probably do consider a reasonable adjustment in that way in the maternity space, which is something that should be always considered for anybody that has any form of like disability or anything like that. And I think it's important in talking about disability, understanding, does that person identify with their neurodiversity being a disability or not? Because I think it sort of also allows you, the clinician, we have a disability identifier, and so we also ask, would you be happy that they can fill it out? It can be self-filled out, or the clinician can fill it out with the woman on our electronic medical record. And so asking her, are you happy for me to flag that you are neurodivergent? And then in that, you can go through that with the woman, and you can tick all the things that need to be ticked, so that as soon as someone even walks up to a clerk, it's just a flag to say, I've got a invisible disability or something. I find that can be helpful. Having an information that they also not going to be asked at each touch point about things. If we've just got, you know, a set of information that can be read easily prior to anyone going in and seeing them and speaking with them, and allowing that support person to play an active role in their postnatal recovery and labour is important. And also for appointments. We can link partners in through telehealth if that they want that, which can be helpful as well. So the person can come in for their face-to-face appointment, but if need be, we can either get the partner on the phone or through telehealth if that's something that they would like as well. And I think also what's helpful is understanding the partner's neurodiversity as well and how that may impact on that. Because even on the postnatal ward, we've had situations where the partners become overwhelmed. So it does definitely help the midwives understanding the partner's considerations as well. People are looking for neuro-affirming care. I think it's really important to recognise that people are looking for that. And so like our referrals have gone up quite significantly over the last 3 or 4 years, people actually seeking neuro-affirming care. And so I think it's important for clinicians to recognise that it is important to people, that they have that consideration. So about a third of our patients, we had like, I think in that sort of 22 year, we had over about 102 patients, and a third of those patients were neurodiverse. And then we'd gone from like a couple of years before, like 12% to like a third of patients, because people are seeking that care. As I said at the start, I think healthcare workers are curious and they're looking for information. And I think a lot of clinicians are unaware. I've spoken about the different levels of neurodiversity. And I think it's important for clinicians to understand, because people have this like, oh, everyone's ADHD now, or everyone's, neurodivergent now. And I think that, like what we spoke about, about the diagnosis, and and understanding that people may not be able to afford to get a diagnosis. And if they are identifying, it's an opportunity to refer to an appropriate service that may be able to have a better conversation about that with them. Because if they're identifying and can't get a diagnosis, then they need to be referred somewhere that can help them with that situation. And because they may be missing out on getting other supports through services like NDIS. And if we just blow that off and ignore that, like we also have the capacity to refer. If, that's, as clinicians, you may not know everything about a situation, but I think we also like working a lot more with our mental health, like our psychologists and psychiatrists now. I think we are collaborating more with them and seeking advice for them in regards to supporting patients. Even if the patient doesn't necessarily want to work with our psychologists, it's still good to have that collaboration from another person might have expertise in the area. So even if, because that's like, I would say if they're not sure and they've got a patient and they don't quite understand it themselves, to reach out to the psychologists in the hospital, email them and ask them, what's their advice? What do they think they should be doing to, what can we do to help this person? Because sometimes, because what I've actually found is like the psychologists know other services in the community, and sometimes they've been able to reach out to other services and stuff because, they know your psychology language and all that sort of thing. And sometimes they can be helpful working as a secondary consultation in the background as well, or the social workers. Yeah. Just there's a lot of damage, I think, being done in the community at the moment with RFK Jr. talking about autism and the conversations that are happening around autism in America. And, you don't know how much that, to people that don't have full awareness, you don't know how much of that is actually influencing the way people are thinking. I'm sure most clinicians know that, autism isn't from having vaccines, but I just think you just wonder in the community here, even in Australia, how much that conversation is affecting how people are being treated, like, and even parents of children that are autistic, you know, like that. It's not like he's basically implying that the parents are doing something. That really worries me. You know, it takes so long to bring awareness, and then to have someone with such a public profile saying that stuff really can be really damaging, and undo years of good work to bring awareness about something. Oh, I just think it's as you know, change and acceptance and equality takes so long to, you know, it's generational, and then someone with such position of, you know, like profile that he has got to be saying the things that he's saying, it just unravels years of work that people have done, and it's offensive to people. You know, what he's saying is offensive. Yeah. As I say, I think, like, I always say, you know, whenever I do talks on different things in regards to disability, I always say, you know, even with, you know, regards to consent to medical procedures and things, not so much in the autistic space, but, you know, other areas of our work, you know, you don't have to know everything. You know, you don't have to know everything. You need to know that you need to know the bones of it all. But if you're not sure, refer on, you know, speak to somebody else, you know, get a bit of an understanding about, as I said, we now, you know, quite often, just because we've got like a secure message that we can do through Epic. And, you know, sometimes the doctor, the obstetrician that's caring for the patient, and one of the psychologists, social worker, and myself, like, we'll just collaborate together just to, even as a secondary consult, if not, you know, get the patient to, because you can't always get the patient to agree to go and see the psychiatrist or psychologist. They may have their community psychologist or psychiatrist, and that's probably great if they do have, and they continue seeing them. But it's good to sort of have, I guess, a little bit of collaboration even from the community team, and so that we do have team care plan meetings with, you know, everybody involved, because I think that's really important to bring the external care team, who quite often know the, you know, person a lot better than what you do as well, obviously with permission from the patient. But I think that can be a really important tool to providing good care as well. I think, you know, your other multidisciplinary teams can just help you with different strategies and different ideas for referrals, or, you know, that sort of thing. So that's where I think you can be collaborative in, you know, using all the other disciplines in the hospital setting to, you know, help in you providing care. Because not everywhere, I guess, you know, some hospitals are bigger than others, have different multidisciplinary levels of, you know, expertise and stuff like that. So, you know, we've even had people from rural hospitals reach out to us to ask what we do. You know, that's just another thing people can do, you know, like look at what is around to help them with secondary consultation or referrals. Because I think there's a real distinction between, I say, kindness and friendliness and treating someone like a child. Like, you're in the you're in the position of power against that person, and you're now starting to treat them like they're lesser or something. So yeah, there's a difference between showing kindness and compassion. But had she been allowed to let that mask drop through those antenatal sessions, and that was like this woman that I keep going back to, that was the scientist. She ended up needing an extended stay. She ended up needing to go over to the general hospital and spend a few days over there. And she was in this toxic relationship. And then, I don't know, I might have told you about her in the past. And then she came back to the hospital. By this time, she's 10 days post having the baby. She hadn't breastfed her baby because she was in a general hospital and the baby was in our nursery. They didn't have a lot of connection with each other because the midwife from the nursery has to have time to take the baby over to the mother at the general hospital and stay with the baby. and that time was very limited. So she'd had little bonding time really with the baby. She'd been so sick herself that she couldn't really breastfeed. She did want to breastfeed. She came back to the maternity hospital and was like, well, she's 10 days postnatal. She's well past discharge. She needs to just go home. And the partner's fine. He's neurotypical. He can teach her. He's been looking after the baby in the nursery. He can teach her when she goes home. And, you know, we had to really advocate and say, you know, like and she identified with having it, or her autism was a disability. And they said, she's a scientist, you know, like I'm sure she's going to be fine. And really advocate and saying that she's very intelligent, but this is a very different situation for her. And it had all started to unravel because she couldn't mask for 10 days. And all of a sudden starts to become the difficult patient because they're not being, because the girls, like, as you know, when they mask, they are very compliant and they hide their emotions, and they've learned through looking at other people. And so when they all of a sudden start to unravel and start to be themselves, they start to present as, she's now just being really difficult. We've done everything for her and she's just being really difficult. And anyway, they ended up keeping her. You know, we really had to add, because this partner lived interstate, you know, like it was such a toxic relationship that she was involved with. So, and sometimes it's like bringing the social worker in as well to talk about what is a healthy relationship. Because, you know, they just sometimes so much want to just be liked by people.
It's so common.
They have trouble, you know, making relationships, and they meet these people on Facebook. Like, we've got another girl at the moment, she, you know, met this guy on a dating site. She wanted to get pregnant. She wanted to have a baby. But then she tried to connect up with him again. Of course, he just ghosted her and didn't want anything. Like, she doesn't even know his name or how to connect with him or anything. She's pregnant. And, you know, it's just, you just hear that story over and over and over again, you know, wanting to be in a relationship, meet somebody on Facebook, meet somebody on a dating site, end up pregnant, and then the person just disappears. Or even, you know, being part of, you know, being sexually exploited in rings of, you know, sexual, you know, pedophilia. I've even had pedophilia rings, you know, like, you know, like it's just, yeah, it's terrible, really. And so
there's no education tailored to autistic people on healthy relationships and
yeah, like what's like because she would initially speak quite highly of him and like, it's me, you know, that whole DV thing. It's me. I'm the difficult person, not them. And then when she went home, she was more than capable of looking after that baby. And he started threatening that he was going to involve child protection. And she was just wanting his help. And because he didn't want to give her help, he was saying, oh, you can't look after a baby and I'm going to bring child protection into this. And then she sort of started talking to me about it and saying, I'm really worried he's going to get child protection, you know, involved. And I just reassured her and said, you are a perfectly capable, okay mother. And I can reassure you right now, if he contacts child protection, you will be okay. Like, because she was not doing anything wrong. You know, I've worked with child protection a lot, and she was so scared to upset him in case he called child protection. And I was just, you know, like, there's no way you would be seen as an unfit mother, you know, like, don't worry about it. You're going to be okay. And I think even just getting that reassurance allowed her to like stand up to him a little bit more. And anyway, he ended up nicking off back to Adelaide, and who knows whatever happened after that. But, you know, like, it's just, yeah. And that was one of the things that when we discharged her, we were saying to the maternal and child health nurse that could she be referred to a service that could help her understand, you know, what a healthy relationship looks like. Yeah.